you today as the recording system. I'd be grateful for my colleagues around the board table, please, to make sure they speak loudly and clearly so that members of the public can hear you. The owl will know that you are speaking and will turn towards you, which is a joy to behold. We've received no questions from the public in advance of today's meeting. We have 3 members of the public signed up to attend today's meeting, so welcome to them. I'm going to take us now to the conflicts of interest register and declarations of any interest relating to this agenda. There are no new conflicts in relation to the full register. Caroline, I will note your conflict of interest in relation to your FHFT role and that you will stay as part of the discussions today.
Thank you very much.
The minutes of the last meeting, please, held on the 21st of May. Are there any amendments or matters arising that we're not picking up in today's agenda? I'm seeing confirmation. May I accept those as a true record? Thank you very much. I'm going to hand now to our Chief Executive, Sam Burrows, for your update, Sam. Thank you.
Thank you, Priya. Good morning, everybody. I'll keep this relatively brief. I'm conscious we've got some items on the agenda today. We want to make sure we've got time to discuss whilst we're together. But just a few points for me that I'd be grateful for the board to note. So, firstly, since we last met in public, we should acknowledge the arrival of the 10-year health plan. This is a potentially seminal moment of the NHS. Thank you. And will be important for us as a part of the broader NHS and health and care construct for moving the NHS onto its next stage of its evolution. The ICB and Frimley fully supports the aspirations set out in the 10-year health plan and will absolutely play our part in making that a reality for the populations which we serve. The 3 shifts which are integral to that, analog to digital, hospital to neighbourhood and sickness to prevention, already form a core part of our strategy, although there is significant further work to do around this to make sure that we can make these things real for local people. I'd also like the board to note this is an extremely challenging period for our staff. It is still the stated intention and national policy to reduce the operating expenditure of ICBs by at least 50%, and for this organisation slightly more than 50%. This creates a huge uncertainty for people who work in this organisation on both a professional and a personal basis. And we should also note that many of our colleagues in the ICB are also part of the population which we serve as well. And we need to pay particular attention to that. From an employer's perspective, we are doing everything that we can to support people, and we're working with our staff representative colleagues to ensure that people are receiving the support that they need. We should also note that even whilst we're going through our change, significant changes continue to be announced around the broader health and care architecture as well. And since we last met as a board, we've had the announcement regarding the dissolution of commissioning support units, dissolution of the Health Watch construct, and also the HSIB, amongst others. Some of these were unexpected, and we're here to support colleagues in those organisations as well, many of whom we work very closely with on a day-to-day basis. As an organisation and as a partnership, we continue to make very good progress on access and quality. Residents in this geography continue to receive what I would regard as a very good service, and access to GP practices, urgent and emergency care services, elective care, diagnostics and cancer continue to be significantly better than national average. I want to say a really heartfelt thank you to colleagues around the table who work in GP practices and primary care, who work in secondary care organisations and our mental health provider as well, for all the work that you do every day to ensure this is a reality for our population. I want to finish also finally by touching on some of the financial pressures facing the organisation as well. And I know that Richard, our CFO, will pick us up in his report to the board. But the public sector across the country is clearly under significant financial pressure, and this ICB is also impacted as well. I would like the board to note that at times we do lack the commissioning policies and levers to control some of this expenditure, and we're particularly facing a pressure right now in demand and access for independent sector treatment in the mental health space. Without the ability to determine how much we can spend and afford to spend in this area within a very finite financial allocation, does mean that we are under significant pressure in this space, And we will need to start exploring some very difficult decisions around what other services we may have to withdraw access to ensure that we can live within the allocation that's made available to us financially. It's really important the board's aware of this, and Rich, I know that you'll pick this up in your report as well. Nothing else I wanted to pick up this morning. Thank you for your effort. Looking forward to our conversation today and the importance of what's on the agenda.
Thank you very much, Sam. And for colleagues around the table, any initial comments or questions? I know that we're picking up all of those issues in our agenda this morning. Thank you. Let's move then to our transition programme update, and that is over to Sam Burrows and to Caroline Corrigan, our Chief People Officer and the Senior Responsible Officer for the transition programme. Over to you, Caroline.
Thank you very much, Chair. Colleagues, I have a few slides just to update on the transition programme. This is material that we, meaning the Bob, Buckinghamshire, Oxford of Berkshire, ICB and ourselves are using to update on the transition programme. First slide. So we're just going to touch on some of the national and regional context, where we are on our programme. We'll also reference the proposed transfers of staff, liabilities, assets, contracts to Hampshire, Isle of Wight and to Surrey, Sussex as part of this update. Thank you, Tom. If we move on, oh, sorry, Ollie, apologies, Ollie. So we have had the 10-year plan published, and just highlighting there to colleagues the signalling of ICBs and the changes to ICBs as a strategic commissioner, as a key component of the system architecture alongside neighbourhoods and integrated health care organisations. We are expecting, following the national announcement, to reduce the number of ICBs to reduce to 26 ICBs, and the construct of Thames Valley ICB. We are expecting ministerial confirmation of the establishment of the Thames Valley ICB very shortly, and the timeline on that, we continue to propose that go live of April 26. So in the context of reduced numbers of ICBs, changing therefore the boundaries of ICBs, our proposal, meaning the Bob ICB and the Frimley ICB, was to confirm the proposal of the establishment of the Thames Valley ICB. That's in the context of the announcement that financially we would reduce the cost of ICBs, and the figure of £19 head of population would result in circa 55% reduction on the current cost of the Frimley and Bob ICB. In terms of the financial environment, there is still ongoing discussion and guidance expected regards the treatment of redundancy costs in the context of that 55% reduction. The other areas we're just highlighting contextually is the dismantling of the National Guardian's Office as announced, Health Watch and CSUs. We're particularly focused on what it means for us now and into the future as CSUs are dismantled. And from a cultural perspective, very considered of the dismantling of the National Guardian's Office and how important freedom to speak up is to us culturally now, but also into the future. So just wanted to make sure colleagues were aware of our focus on that as well. We've had the Model ICB blueprint, and we're expecting further materials to be published later this month, which would include, we understand, best practice guidance on consideration of our responsibilities for CHC or all age continuing care. In addition, national regional colleagues are working on guidance around the shape and remit of regions going forward. And we continue to support that work through our networks as that material is expected to be published over the coming weeks. We also noted, of course, that the Department of Health and Social Care with NHS England also published their senior leadership structures, and as part of the context in which we're operating, we note that and use that as part of our planning tools as well. Moving on, please, Ollie. In terms of regional context, we're expecting the finalisation of the processes as we look at Thames Valley ICB for the chair and chief executive appointment processes. We expect the chair process to be concluded by the end of this month, and that will then enable the appointment of the Thames Valley ICB chief executive and other ICBs across the South East and nationally. There is a voluntary redundancy scheme, a national scheme. We've seen draft of the model. It is still under development, and we'll be sharing that as soon as that's available to us. In the context of making the sorts of reductions and the expected redundancies associated, we are keen to have that voluntary redundancy scheme available to our staff in both organisations. In addition to the CSU announcement across the South East, ICBs are also discussing, as part of their design work, function mapping and where it would make sense to collaborate and undertake functions once across the South East. Active work in that area, we play our part in that. And lastly, just to note that the governance around delegated commissioning that this board previously signed off and did the other 6 ICBs in the South East, whilst the committee's not met, that we will continue with those arrangements and expecting that committee to meet over the next 6-8 week period. Thanks, Ollie. Honing in on the specifics for us in terms of a joint transition programme. So with the Bob ICB, we had agreed a mandate to cluster using the national guidance. We are expecting to formalise that clustering using national guidance so that that would go live from the 1st of October, subject to obviously the establishment and the go ahead from ministers of the establishment of Thames Valley ICB. So in September, board colleagues will be, paper will be put forward to enact that formal clustering through a collaboration agreement. Work to design the new Thames Valley ICB is underway, and both organisations, Bob ICB and ourselves, are engaging at executive and at staff level to commence the work with the reduced costings that we financial envelope that we have. That has started in earnest as we prepare for the establishment of Thames Valley ICB as we plan for April 26th. We continue to support our staff, not just with briefings, but with our recognised trade unions in both Bob and Frimley ICB on not just the design process, but support to staff through change, considering the scale of reductions. Importantly, the changes to the Frimley ICB include transfers of people, our staff, our assets, liabilities, contracts, our relationships with our colleagues in Hampshire Isle of Wight and the Surrey Sussex ICB. We've got three-way working, very active with those colleagues to enable the transfer to coincide with the boundary changes as we expect ministerial approval of the Thames Valley ICB. So a critical piece of work for us, as important as establishment of the Thames Valley ICB, is the care and attention we will pay to those boundary changes and enabling safe transfer. Key risks to flag to the board, to both boards, is obviously engagement of our staff, morale, as we continue to deliver the plan for break even this year, our ambitions on transformation, as we also face into the transition programme. We pay particular attention to stakeholder engagement, and by that I mean all of our partners, particularly in Frimley, and engaging well with a rather complex programme of transition, and ensuring that we engage with partners on that programme of work. That's our summary of the transition programme. Ollie, if we just move on. I've just highlighted here, I've given you the heads up that the work on a collaboration agreement, consideration of the both boards mandating against national guidance the clustering arrangements. So provided a little more detail of the shape of the material that will be brought forward to the board in September. Moving on, Ollie, that will take the shape of a proposed joint committee, and the materials, as I say, that we will bring to the September board will flesh that out for formal agreement. I'm going to end the transition update to that point, but ask Sam, as interim chief executive, to highlight any additional items nationally, regionally, or locally for us.
Caroline, I think it's an incredibly comprehensive update. Thank you. Nothing to add, and very happy to commend it to the board and to open up for any questions that people might have.
Thank you both. Very clear. At a time of significant change, and for everybody involved in system working. Comments or questions, please. Involved. Yeah.
Thank you, Chair. Caroline, are you able to give us any more colour on staff morale and how that's playing out since the last board meeting, how it's looking going forward?
I think it's, as we said, we start from a risk perspective, and it's obvious, isn't it, that we would be worried and concerned. To add a bit more colour, we've launched the organisation design process and asked staff to get involved with that. As an indication, as of yesterday, over 120 staff had signed up for those workshops. So there is real interest in having voice, in taking the opportunity to shape the Thames Valley ICB. A second area is the feedback we've had through staff briefings, particularly in Frimley, where staff have asked us, and we've set up dedicated sessions for the staff that think they're going to be in scope for transfer to Hampshire Isle of Wight and to Surrey Heartlands. So there was whilst we've got really good staff partnership arrangements and continue to value and respect, particularly the engagement of our trade unions, we quickly heard from our staff that they wanted dedicated sessions. This transition programme is multifaceted, and sometimes giving an update on everything you can lose, or it can start to feel some areas aren't as important as others. So dedicated sessions are being set up for staff who believe they may be in scope, they know they're in scope, so we're keeping it really broad. Last area, the staff that we act as a hub for in terms of pharmacy, optometry and dentistry pod staff similarly came forward to us and said, we're feeling a bit lost in this process. We're hearing this nationally, we're seeing that going on regionally on networks. We'd like a dedicated session. So again, we're responding as we hear from staff that they want more time, want more attention, want something different, as well as maintaining what's ended up being a fortnightly briefing session to staff about transition in all of its sizes. Last thing I'd say is our staff networks continue to be vitally important to us. And I don't know, Sabina, just putting you on the spot, whether you might want to add anything from your perspective on staff.
Yeah, I think what's really important is we keeping their mechanisms of communication open for the people that might feel more kind of vulnerable. So the speak up role, the networks, and creating them mechanisms that people can speak up or talk about anything that's worrying them. So regular contact with the people that network and that role around the Guardian is really key as well.
Last thing to say, I'm painting all the positives and the response. Nick and Sam have talked to us as a programme, the transition programme, about can we do some perhaps pulse checks during this next 6 to 8 month period. We don't think the National Staff Survey at a point in time is going to deliver perhaps some of the rigour around staff experience over the next period. So it's something we're working through the joint transition programme to look at a more regular testing of staff experience through the change.
Many thanks.
Such an important point now. And as the accountable officer for the organisation, and I've made it a real point of trying to get out and talk to people who work in it. Whether that's through one-to-one conversations or through the fortnightly staff briefings. Actually, they're often more than fortnightly, aren't they? Because as things change around us, we want to make sure that our staff hear it from us first, and they don't pick it up through rumour or through the media. And there was one thing I've noticed that I just really want to put on the record for our meeting today, and that is every time I have a conversation with the staff group, I'm so impressed with the level of professionalism and dedication that they show, but the vast majority of the time to get on with the job and to continue to go the extra mile for population. And I think the fact that our colleagues turn up day in, day out and do that at a time when they've got very natural and understandable concerns around their own livelihoods and around their ability to continue with their own lives, whichever form they go on, I think is really, really important for us to know to acknowledge as a board. Thank you.
I think we can all echo that, and we're going to move to our next item, which is system transformation and financial recovery update. And these elements of system transformation are the things that our staff tell us are hugely important, making this change, making this impact at a time when other parts of moving has been very important for people. So thank you. I'm going to hand now to Lalitha Iyer, our Chief Medical Officer, and Mark Selman, our Chief Transformation and Information Officer. Thank you both.
Thank you, Chair. Thank you, Ollie. I'm really excited to talk about this seminal piece of work, which our teams have created and will share a measurement framework that we've created. This presentation, Ollie, if you want to move to the next slide, please. This presentation talks to you about the System Priorities Transformation Board, which, as you all know, reports into this ICB board. And the key purpose of this is to improve how transformation change is delivered across the health and care system, not just at an ICB level, but also providing provider organizations the support to coordinate and drive change, to be effective and to be results driven. So we're offering simple, practical approaches to track delivery and indeed track outcome in terms of impact at a population health level. And through this measurement framework, we can actually shine a light on what's working in real time almost by highlighting interventions that are delivering against key priorities for us as a system. And we can also identify where gaps are, tackle them as we go along, and there may be trade-offs that we can make informed decisions on. So giving leaders the insight to make informed strategic decisions. Could you go to the next slide, please? Thank you, Ollie. So this slide is a busy one, but essentially highlights some of our key transformation projects, such as primary care transformation, referral information, urgent care transformation, and so on. And the emphasis is on relationship building and collaboration. The measurement framework shows where the outcomes are defined and gaps identified, as I mentioned, and with unifying all the projects under the system-wide approach with shared understanding of the impact on the population. And I just want to note that this is a different way of doing things. We've never done this before. We've mapped the project, but this is about mapping actual outcomes as we go along. And I just want to add that we have had conversations with our directors of public health, and we are working really hard to ensure that all the prevention priorities as agreed by our Living Well Board is also mapped into this. We are keen to ensure that we can see disaggregated data on this dashboard, because we are keen on addressing inequalities as we go along. And I just wanted to touch on a recent paper by the King's Fund on prevention, which suggested that CVD prevention is one of the key things that ICBs can do when we're looking at prevention. It's probably one of the most effective interventions. And many of you know that we have detailed data on CVD prevention, disaggregated data as well. And we were commended not just for being quite high up nationally, but also the fact that right through when we came out of COVID, the inequality gap, particularly in CVD prevention, was in fact very narrow, and at some point even reversed, where we had areas of inequalities doing even better than the other areas. So having said that, I'll hand over to Mark to take us through a little bit of the framework itself.
Thank you. Next slide, please. On. Are you able to move it to the next slide, please? Thank you. This is the conceptual framework that's been reviewed at this board before in terms of some of the outputs and outcomes that we're seeking to influence through the work that we've been undertaking with partner organisations, programmes work. We were looking for some validation that this was a sensible set of components to be looking at. And actually, through that work, we've tracked 358 indicators that now feed into this framework. And just really building on some of the points that Letha was raising, a significant proportion of those are orientated to probably what deemed more performance orientated metrics or financial ones, which are really, really important. But I think it's also equally important for this board to be aware and scrutinising the impact we're having on reducing inequalities, improving patient outcomes, and living healthier for longer, for instance, as one of our key approaches. And that's where, as an organisation, as an ICB organisation, we're going to be able to do a huge amount, but not in isolation. We need to work with local authority partners and others, and through the board that Karen chairs and is steering, we're really encouraging for everyone to contribute into this so we can get a system view of all the things that will influence things like improving delivery of care, using resources effectively. So I think we're making some really good strides, and we're seeking to continue to use this as a vehicle to present transparently to the board how we're progressing against our key strategic objectives.
Thank you. Which do you want to come in?
If I may, yeah, just very briefly, and just picking up on something that Mark said there. So keeping people healthier for longer, helping people stay healthier for longer, and addressing health inequalities are key facets of NHS productivity, which are not necessarily measured and are ignored in the national conversation about NHS productivity. There is a direct financial impact in the sense that if we reduce the demand for necessary health interventions, then we can reduce the capacity needed to service those health interventions and thus save costs. But also in that productivity conversation, it is really important to note that if we can keep patients who do not necessarily need to deteriorate to the point at which they need a health intervention healthier, so that they don't need a health intervention, we don't measure that output. Those who we cannot keep in that space are by definition at the point where they need a health intervention more acutely ill on average than otherwise would be the case, because we're keeping people healthier. And that is something that we need to address. The measurement of that is something that we need to address in order to inform the productivity conversation going forward. Strategic measurement.
Thank you. Go ahead, Cedric.
Yeah, just reinforce some of the key messages that both you talked about. I think it would be helpful to all to see the mix of initiatives across all the different areas of the life cycle. So all the aspects of the next shift, what are we doing in prevention, what are we doing in community based, as well as what we're doing in acute, and seeing what are those key initiatives in each of those different categories. I think the second point is let's keep a very visible lens on what is transformation doing to the most deprived areas. Sometimes it actually indirectly exacerbates it because, you know, we implement a huge digital infrastructure, and guess what? The poorest people in our communities can't actually jump on that channel or can't leverage that opportunity. So as we're going through the transformation, that lens of the most deprived areas can absolutely be paramount in what we're doing. And obviously the last point is with everything else that's going on, and Caroline mentioned, you know, how can we as a board help support you better? Because what we don't want to do is, you know, end up just focusing on the immediate short-term pressures, which we know will end up. We obviously have the three horizon model, but it's obviously really important as a board that we focus on all of them, and that we support the management team as far as possible in terms of helping you do that.
Thank you.
Thank you very much. It was really good to read these slides and hear what you were adding to in your comments this morning, or this afternoon actually. And in particular, I like the way the framework draws attention to the results that you're hoping to achieve through all this transformation activity. And in my mind, I really encourage you to take that step further and think about how we collectively hold ourselves to account, because we're making investments, whether it's people's time or cash, to drive this transformation, and we want to be assured that we're having the impact that we hope to. So I'm hoping that behind the scenes there's a developing piece around how we'll demonstrate the impact of these various initiatives and be clear where, you know, some might do better than we thought, hooray, some might not, and we have to change tack, and being able to do that in a kind of fleet of foot way is really important. So I just wanted to throw that into the comments. Thank you very much.
Thank you.
I come back to say thank you first of all, and we hope that by coming into the board regularly, you can enable us and give that support that you mentioned. I just wanted to touch on two examples which sit under probably the urgent care umbrella. So we know that virtual wards have been quite instrumental in keeping people out of hospital quite effectively, but we also know that in Frimley, we have remote monitoring, which then keeps people healthy, whatever point they may be in their frailty journey and in their age range. So right from the start of both projects, we've been quite keen on mapping the impact of the transformation, just like you said, Sajad, on the deprived and on the populations who might have language barriers because of ethnicity and so on. And data showed us very clearly, for example, in remote monitoring, that the remote monitoring was effective in keeping people safe at home, but it's also shown us that the discrepancy doesn't exist, and actually we're catering to all levels of our population equally well. And in fact, we found that there were more people from the group that you would consider having inequalities represented in the remote monitoring population, and that was really heartening to see. So we hope to continue that kind of disaggregated data mapping for every project that we are looking at.
Thank you. Three really quick points from me. Firstly, just a really big thank you for the progress that's been made in 12 weeks. I think it's absolutely superb. This is a core part of our business. It's going to continue to be a core part of our business in the future. I know you've had great support from colleagues on the board as well. And Karen, thank you for the role you play on the transformation board. I think it's really great to see the progress. Sajad, the point you make is spot on. We have to bring a 10-year plan to life. I think this is all a part of that process. Bringing it back to resident story, resident benefit, what actually is this change that's tangible that we can describe to people in their day-to-day lives, and we've got to keep coming back to that. And then finally, there was a real national commitment to increasing the level of transparency that our members of the public have in terms of performance on NHS services, and I really welcome that. But it's also, for me, equally important that we have transparency in our delivery of change, particularly at a point in time when we're embarking on some really significant change. So being able to track and demonstrate to this board and our public what changes we're delivering, what the outcomes and the benefits are for the populations that we serve, feels really critical to me. One should obviously keep the other. But huge thank you.
Thank you very much, everybody. Really helpful and full support for that. And thank you, Karen, for chairing that board subcommittee. Let's move now to our anti-racism update, and I'll move to Safina Nadeem, our EDI lead, on behalf of both you and Alex Guild, who's unable to be with us for this session. And I would just encourage board members, please, to adopt this volume, which helps the owl enormously.
Yeah, I'll try and be really loud. People hear me? Yeah. So yeah, it was Alex and I that we led the work around anti-racism, but board members will know we've been discussing this right at the formation of our board in 2022 around being an anti-racist system. And as an ICB, we have been supporting our partner organisations deliver anti-racism work and principles. I think last year we saw the riots and we saw lots of engagement with our colleagues in the system and the sharing of their lived experience. And as a direct response to that, we developed an anti-racism alliance with our partners across the organisation, which meets bi-monthly. We've got really good representation from local authorities, NHS, voluntary sector, Thames Valley Police, fire and rescue. So we've got lots of kind of system partners in that space. And as a direct response, I suppose, to organisations in our system wanting to do anti-racism work but not knowing where to start. And I think for bigger organisations like the HFT, they kind of ran with their strategy and delivered. Smaller kind of organisations wanted some support. So the direct response to that, we've developed this anti-racism framework. We've done lots of engagement for the last kind of 6 to 9 months. We've been engaging with our partners and we've got products. I'm really excited. We've got here finally. The framework's designed for organisations to use that themselves and kind of benchmark themselves internally around where they are and where they feel they are in terms of their anti-racism work. So it is designed for any organisation to use internally. And there's a process around peer review where if people want to kind of benchmark themselves on a different maturity level, so there's a process where peer support can be given to our partners to kind of assess them. It's not obviously mandatory, but what we're doing, Alex and I, is really speaking to organisations around the benefits of being an anti-racism organisation and considering all the work that's all the statistics we're seeing around health inequalities for Black minority ethnic communities, workforce race equality. We've seen the latest RES data from the NHS saying there's lots of work still to do around race equality, and then a number of hate crimes that we're seeing as well in our community. And I'm really trying to get organisations to understand the benefits of doing this work and really supporting to put this framework in place. I'll stop there, but yeah, I'm happy to take any questions or thoughts from anyone.
Thank you very much. And let me open it up now to board members for comments or questions. Hello.
Thank you. Hopefully this is loud enough. I'm normally quite loud actually, but I really like the framework. So thank you very much to you and colleagues for all the work that's gone into it. And my question was just about how you're going to keep track on its use, and I guess keep that feedback loop going, because it looks really great to me, but I guess as it gets used by different organisations, and they may have reflections that can help others that may not already be captured here. So how do you keep it fresh, and how do you kind of know anything about uptake and the impact it's having?
Yeah, so I think that'll be through the Anti-Racism Alliance that we've got. So that's has partner membership, meets bi-monthly, and chaired by myself and Alex and Sue Halliwell's championing that from Blackburn Council as well. So I think that'll be the main area place where people come and say, this is, we need support in this. So yeah, I think that'll be it.
Thank you.
But then regular updates to this board, I think, whatever formation it has, would be helpful as well.
Thank you. And so,
Sophia won't blow her own trumpet, but we raised this at the regional quality group, and they were so impressed by the other ICBs across the region that they wanted to go and present this so that they could think about how they might implement it in their area.
very good to hear. Thank you very much for all the work that's gone on and your leadership and Alex's in getting us to this point. Thank you, everybody. I'm going to move us now to our performance reporting. So quality, finance and workforce. And I'll hand over first to our Chief Nurse, Sarah Bellis. Thank you, Sarah.
Thank you. And those of you that are very observant will note that it says March 25. But as you'll see, some of the data relates to the spring COVID vaccine campaign, which started after then. You can be assured that the report isn't that delayed. So if we start on page 4 of the report, which is about the sexual assault referral centres, or lovingly known as the SARC, this was a nationally recommissioned piece of work, and this has resulted in changes in services for us locally. This has meant a change in the area in which the service was provided, but more importantly, there'd been a gap or an omission in the service specification, which meant that there were potential inequities for children when they were being seen in the SARC. We worked with NHS England and with the local provider to address this issue because it had serious consequences, and we've managed to be successful in getting that service changed, which was really important. And we've raised all of our concerns through the relevant groups. And I hadn't noted here, but we did actually raise it with the safeguarding board as well, because it was concerning us so much. We move to the next slide, which is about the COVID seasonal spring vaccination data. I think we are beginning to, the reason for bringing this particular one was we are finding it more and more challenging to maintain rates for COVID vaccinations, and you can see both the national South East and the Frimley levels. We have tried to focus on our most vulnerable residents, and as you'll see that we have the highest uptake of care home residents being vaccinated. As we saw through the pandemic, they're very vulnerable in that contained environment and things, so we've been really focusing on that. I think we need to focus on things like our immunosuppressed adults as we move forward into the winter campaigns. Vaccination is something that, especially around COVID and flu, is a real challenge, especially amongst our staff. And we've got a programme at the moment over the summer to think about how we increase some of the staff uptake this winter, as it's one of the single most important things that we can do alongside hand washing. We've included some of the complaints data. This complaint data is the annual review. It doesn't include in the main the complaints about the GP and the primary care side of things, because that up until April this year was done in a separate way. We do have that data, and there were about 60 primary care complaints last year, and we can share the things and trends another day, but it gives you that. We've also included the Health Watch Surrey data, which mirrors the data that we had from the complaints. I take you on to the safeguarding data. Just a couple of things I wanted to say. If you look at the data that we look at in relation to child death, we continue our campaign about water safety, and especially evident at this time of year. As you'll remember that in 22-23 we had a significant number of drownings, and we would like to carry on the trend that we saw in 23, 24 and 24-25, and so that continues with a lot of gusto in that area. And so hopefully you have seen some of the stuff that we put out around that, working with our local authorities, of course. And then the other area that we are focusing on is campaigns around sudden unexplained deaths in infancy and safe sleeping campaigns. And then if we move to CQC updates to the last slide, it's probably just pleasing to know that of our 66 practices, all of them are rated good with one has a required improvement. And with the exception of the ambulance providers, all of our providers in the local area meet the standard of good or above in relation to this.
Thank you very much.
Really, thank you. Really quick point from me on vaccination, Sarah. Thank you. The board, we have to know vaccination for COVID and flu is the most effective weapon in the arsenal we have for avoiding admission to hospital. And I'm really mindful as we sit here in July that when we meet again in public, it will be September, and we'll probably have our first conversation about the winter plan. We must make sure we pay attention to what our vaccination plan is that period. So if we could just note that before we come back again after the summer, because it's absolutely.
And I think you probably have a focus on staff vaccination. Staff vaccination is exceptionally challenging now. This is following the compulsory vaccination mandate during COVID, and staff are exercising their right to choose. In addition to Sam's point around it being effective for preventing admission to hospital for patients and for that transfer on, we have a duty under the Health and Safety Act to ensure as many of our staff are vaccinated as possible. We are looking at positive ways of trying to encourage staff, and one of the things that I'm going to talk to Rich about is how we might engage in the UNICEF programme across the system about a jab for a jab, which is not an expensive way of doing it, but often has been really positive in encouraging staff to take it.
Just on the vaccination, some of the kind of more tertiary and secondary reporting is you don't seem to be treating the 95% on some of the normal vaccines, not just COVID and whatever. And that's consistently over multiple years. Is there a sense that there is a new strategy to get these things better done, or are we kind of up against a certain level of fake news, national misinformation and whatever? But what I'm concerned about is that is the biggest kind of lever in our arsenal, but we're not consistently hitting even amber. What can we do differently?
But it is a national challenge. It is an absolute national challenge about misinformation. I completely agree with you, and it's different per vaccination. It's not even something that you can see consistently across, so that we do have to look at it from a targeted point of view, both in terms of what the vaccination is, where and who the group is we're trying to vaccinate. Depends. You will have seen that there have been reported nationally some measles outbreaks and things, and so now is a really good time to try and positively encourage people to take up measles vaccinations, because there's been some really tragic stories in relation to unvaccinated children, which nobody would wish for any child. And I think so sometimes it's really important that we have that balance in understanding things of the risk of vaccination versus the risk of not being vaccinated. And clearly, you know, that the less people have vaccinated, the less herd immunity we have, and the more likely we'll get the outbreak, and the more likely to get that. And some of the perceptions that we have to change is things like measles is a normal childhood disease. It's not. It might have been when some of us were little, but it is not now.
Thank you very much, everyone. A bit, Ronald?
Thank you, Chair. The quality item, the safeguarding update, found it really helpful. One of the things we're trying to challenge ourselves on is, are we assured that we are applying learning from reviews and themes of reviews as local systems? And it's an area that we're going to look at going forward. I was just wondering, in relation to lack of use of the multi-agency risk framework, do you have any observations about what we could potentially do together to increase people's knowledge and use of that? So as a partnership, in terms of our local partnerships, we can ensure that that is further strengthened and enhanced.
I think there's two parts to that answer, and thank you for asking that question. I mean, you're aware that we have a strategic health safeguarding group that the business managers from the different safeguarding boards attend, so that we can get that coordinated response. So all of the reviews feed into that meeting, and we share information about the multi-agency risk framework and all of the themes that come out. I think it is making things as simple as possible and as easy as possible for people to access, and making sure there are no differences. The good thing about Berkshire is that although there are 6 local authorities in the main, they do try to have some consistency over policies and forms and things, because I think for clinicians on the front line who are really busy, it has to be as easy as possible and a push mechanism, not something that they've got to search for. But anything that is different in any area will make it more challenging. I suspect that's my biggest piece of advice. Difference will make completion of the template more difficult.
Let me hand over then to Richard Chapman, our Chief Finance Officer.
Thank you, Chair. So we're not putting slides up on the screen because I'm going to reorder things slightly. But the public report contains the ICB's capital plan, which the board is asked to note. That plan contains the ICB's regular business as usual capital, which totals just over £1.4 million, and about £500,000 of that will be spent on replacing IT equipment in primary care, which is out of warranty, £945,000, and we are planning to spend on minor improvement grants in GP surgeries. Additionally to that, the ICB was successful in bidding for £1.2 million of funds made available to the National Utilisation and Modernisation Fund for Primary Care, which will be committed in line with bids submitted, and that's the entirety of the capital available to the ICB, which is in that plan, and the board is asked to note that plan. In terms of performance, there is across the system, there is pressure as we are seeing in national patterns, but as Sam described in his Chief Exec's report, we continue to provide good access across primary care, cancer and other indicators in spite of that continued high demand pressure. It is challenging. We are seeing a slight slippage in ED 4-hour wait, and we are working hard with our system partners to get those indicators back on track. On the in-year revenue position, the position contained within the report is the month 2 position, both for the system and for the ICB itself. FHFT and the ICB are the 2 constituent bodies within the system, and both are on plan at month 2. But we entered the year with material high risk and unidentified savings requirements, and our system partners face similarly challenging situations, and that's not limited to ourselves in FHFT, but also Berkshire Healthcare and Surrey Borders Partnership Trust, in line with organisations nationally. Everybody is challenged. At month 2, we've made significant progress closing the unidentified gaps and progressing the delivery of high risk cost saving schemes, but we are facing considerable emerging unanticipated cost pressures. And there are 4 key elements there. One is acute spend with the independent sector. There is a pressure in packages of care delivered under Section 117 of the Mental Health Act, and spend in optometry services, for which commissioning responsibility was delegated from NHS England in April 2024. The main pressure, though, the most material pressure that we're seeing, is independent sector ADHD assessments for adults under Right to Choose. We set our budget in line with last year's outturn position. It was just over £2 million for the year, but we are seeing a straight line extrapolation of what has been delivered year to date, with a pressure of about £3.5 million on top of that budget. And providers are indicating plans to deliver considerably more than that before the end of the financial year, creating a potential cost pressure which could be up to £8 million. We are, as Sam described, limited in the levers that we have to control that spend. We are working hard to apply those levers that we do have as rapidly as possible, but that type of pressure may lead to some very difficult decisions as we move forward through the year in terms of what resource cannot be committed elsewhere if we are required to continue to fund that cost pressure. Happy to take any questions on that, Chair.
Comments and questions? This raises an inevitable tension, doesn't it, with the financial constraints that mean that we must deliver care at the most effective, efficient unit cost, whilst at the same time we have national provisions that mean patient choice creates its own cost. And we have to be clear about the commissioning levers that we do have, and therefore what the consequences are if we're not able to manage or contain some of those costs. There will only ever be a finite envelope, and so something else will have to reduce if we can't contain those costs. Any other comments or questions in relation to the in-year position, finance and performance? Thank you. I'll hand over to our Chief People Officer, Caroline Corrigan, for our workforce update.
Thank you, Priya. The slides as circulated, I'll just draw out some highlights. In terms of the first workforce metrics, that's our system metrics highlights. So FHFT, BHFT and SABP are 3 trusts on or under plan in terms at month 2. The next slide provides the ICB workforce metrics. So as a statutory employer, key metrics for our 366 full-time equivalent staff, and gives a range of metrics around sickness absence, turnover, etc. What we're noticing here is we still are an organisation of relatively low turnover, low sickness absence, but we have seen a slight spike in increased short-term absence. Continuing to support line managers in each of our teams and directorates with that. But the overall picture is still of an organisation with low turnover, low sickness absence levels in particular. And given the change programme, so the close down of both the Frimley and Bold ICBs with the establishment of a new ICB, our vacancy freeze continues to be in place, and what you're seeing here in terms of a couple of starters will be staff as part of posted teams or who have completed onboarding processes. The second part of the report is the main programmes of work. I'm just going to touch on the temporary staffing collaborative that is the next slide. Thanks, Ollie. Which hosted by the Frimley ICB. I'm the SRO for that programme, and Julian Enns, Chief Exec of BHFT, is the executive sponsor for the temporary staffing programme. So this is a programme that operates across all 27 trusts in the South East region. The team have pivoted to provide support to all trusts in relation to planned industrial action by resident doctors. The team have previously supported all trusts as we faced industrial action in the past, and as I say, team pivoting to support trusts with sharing information about planned practice, including rate of pay. The main programme of work for the temporary staffing programme is the medical staffing piece, on track and now working specifically with 12 trusts in the South East who are seeking to align and regularise what's paid in terms of medical staffing rates in particular. The onward reports are primary care training hub information. So this is the workforce planning support for the training, retaining and reform agenda for primary care workforce. Continues in large part to be on track, and talking to the team more recently in the context of the change and transition programmes, spending time with the team about future form and function as we look towards the Thames Valley ICB. The Workwell programme is on track, so we are one of 12 sites up and down the country, working with DWP to support people into employment. Our top line on this one is our numbers are lower than projected in the pilot areas, and providing now dedicated support to the teams to try and track back through to the transformation numbers originally predicted. Lastly, on the Frimley Academy, so uniquely the Frimley system invests in system leadership programs. The reporting there just highlighting that we have paused our programs in light of the transition agenda, but this forms part of a key piece of the architectural organisation design that will fall through as part of the Thames Valley ICB discussions. But just the board asked to note that we have paused those programmes at this point. Thank you.
Thank you very much. Any comments and questions? Thank you. I will move us then to our board assurance framework, and back to you, Caroline, please.
Thank you. Colleagues have seen the paper and detail. We have the board has previously reviewed back in May 2025. We've undertaken a process to review strategic objectives and associated risks. Given the publishment of the Model ICB and subsequent transition programme, we have incorporated some of the risks associated with that, and have had feedback from board colleagues that we should add to our strategic objectives and capture better the scale of transition we are facing into, such that the back would be updated to have an additional objective and associated risk with regards to that transition programme, the effective close down of the Frimley ICB, and our role in establishing the new ICB. So whilst not covered in this paper, we're asking the board to note the work and the position of the back. I'm adjusting now the recommendation in this paper to say we need to formally add a new strategic objective and associated risk with regards to the transition programme.
Thank you very much. Comments, questions?
Sorry, one last area I didn't mention was following board feedback, the cyber principal risk was added to the strategic objective 6 under outstanding use of resources of board colleagues core. That's been a topic of conversation over the past couple of months. So we captured that one, but need to add an additional objective now on transition.
The NHS will then put that in the quiet strategy.
Cyber risk. Yes, yes. Thank you. We have confirmation of the seventh risk to add, seventh objective to add to our strategic objectives. Thank you to board colleagues for all the input around that, and we will outline that in the next iteration of the back. Any final comments or questions on that, or any of the performance reports? Thank you. We have no questions from the public today, so I will just look around the table and ask colleagues if there's any other business. Thank you again. I'm going to close our meeting. We're next meeting in public on the 16th of September, and apologies again for our slightly late start. Thank you, everybody. Bye-bye.